Welcome, everyone. My name is Aisha Delaney-Brumsey. I'm the director of the Behavioral Health Division at the Council of State Governments Justice Center. I'll be your host today, so I'm really excited to be here. And we're really excited for Dr. Harbin's featured presentation on standardized billing for crisis care and moving from state to state models to a national model. Could I get the next slide? So as always, we're really excited to see how many people participate in these crisis jams. One note here, if you are with a Medicaid authority and you do not see that your state is represented here, please reach out to us. We want to make sure that we're capturing and making sure that people are being shown to be participating. As always, you can go to the website, the Crisis Talk website. All of the information that you need for these Crisis Jam learning communities are there, including the Zoom link. You can see what's coming up for the next session, and you can get past videos as well as materials for all of the sessions. So that's a great resource for you to be looking at, particularly if you happen to need to miss a week. The next thing I want to draw your attention to is we have 4 really interesting news articles that are posted on the Crisis Now website. The first one, and if Dr. Goldman's here, I'll ask him to put a little bit of information in the chat about this. This first one is focused on San Francisco's Tenderloin Community and a big mayoral initiative to address long-standing rates of overdose and overdose deaths in that neighborhood in San Francisco, and some of the good work that's being led there and that Dr. Goldman is involved in as well. Thanks. This next article, I think the people on the phone will find really interesting. It addresses the trauma that young men of color experience. The rates of trauma are high among young men of color, as it is high among many communities. But this really focuses on the idea that for far too long, addressing those needs has not been shaped by the young men themselves. And so this work here is focused on how young men of color are doing their own work and is talking about what they need and shaping the community's response to their trauma and their healing. This slide here is an article from the AP talking about the aftermath of the State of the Union and the Biden-Harris administration's efforts to really tackle gaps in mental health care, crisis care. Next slide. And finally, this article talks about the challenges of finding mental health counseling right now, not just, and including in the private market and some of the gaps that we're seeing. And one note that I would say is we all know that these last several years have been particularly challenging. I mean, you all on the phone because you do work around crisis services. And so thinking about really how these gaps are affecting all of us and our ability to do this work and live full lives is really important. So this article is a great resource to get a sense of the lay of the land. Next slide. This quote here from Amy Brinkley is a nice place to set a tone for this conversation. It's truly a game changer for the person in services who received messaging that people care. And I think we're all aware that what we really want in life is a sense and an understanding that we are cared for and that we are known. And so this quote speaks to the fact that when provided well and effectively, crisis services can support that sense of well-being and connection and care in a way that's deeply meaningful for people. Next slide. And so now I'd like to bring up Dr. Henry Harbin to talk about standardized billing for crisis care. Dr. Harbin has been a leader in this field for a long time and a national expert, and has been thinking about how billing can be used to push for parity, and is now turning his attention to the space of crisis care. So Dr. Harbin, can I bring you up to walk us through this exciting presentation?
He just sent me a note that he's having trouble getting in. Let me,
Well, then would it make sense to go to some of the items after this and then circle back to his presentation?
I think that probably makes sense, and I will quickly try to help him get in here.
Okay, great. Why don't we go ahead to the next item up, which if Sarah Corcoran, if you're on, what we could do is we could move ahead all the way to our trivia hot seat. Okay, great, Sarah. Thank you for being willing to do this a little bit earlier. Could I get the slides for the trivia hot seat up?
I also think I see Dr. Harbin. If you want to stay with the presentation, I'll come back later.
Great. Okay. Dr. Harbin, I'm glad you're able to join us. We were going to give you a minute to get on. But nice to have you. I did the introduction and said that folks would be hearing from you about standardized billing for crisis care and how that's going to be helping to push for parity. So can I turn to you?
All right, you want to turn to me?
Yes.
Okay, can you hear me okay?
You're coming through loud and clear to me.
All right, great. So thank you a lot for inviting me. So somebody's going to work the slides for me, is that right?
Yes, I'll take care of that.
Okay, so what I want to talk today, and I appreciate you all inviting me to this crisis call, is really to talk about how can we expand and reimbursement for this range of essential services for crisis services. One of the important ways I think that crisis service can be expanded is to get multi-insurer reimbursement, and that includes commercial, Medicaid waivers or Medicaid standard reimbursements, Medicare, VA, the whole range. This is, I saw your slide on the president's comments about gaps in care in the State of the Union speech. It was great to see the president, highlighting so many problems that they're going to try to address in mental health. I would say crisis services and this level of care is probably one of the areas we have the biggest gaps in terms of meeting the needs for people with mental health and substance abuse problems, because, it's urgency, it's a crisis, and we don't have we do not have adequate or even certainly ideal access to these levels of care. So could you go on to the next slide? So what we want to talk about, and I want to thank Brian Hepburn and Nashbit and Samsa, and particularly David and Paul and others for their help in developing this paper. It's basically it's a sustainable funding for crisis services, the full range. We'll get into a little bit of the details. But essentially, the goal here was to develop some standardized billing codes that current crisis providers could use to get reimbursed for several levels. We did not, as you will see as we go through this, we didn't try to address 24-hour crisis service, even though there's a need for that, because the billing mechanisms of that are quite variable from state to state and insurer to insurer. But the goal here was to identify there's several levels of crisis services and recommend a standard billing code, which we'll see as we go through the slides, so that all insurers could recognize that and hopefully reimburse for that. I also want to thank the Meadows Mental Health Policy Institute and the Bowman Family Foundation, because they helped support the launch of this. But really, the mainstream work was done by Paul and David and Brian, and with help from Brenda Jackson and Melissa Rowan. So can we go on to the next slide? So this paper is in a sense a complement to or an extension of the good work that Samsa did on laying out their review of crisis services, where they identified what these services are, the evidence for them. And there was some of the pieces that are in this paper, in that billing paper, in that white paper, an overview of crisis services. But this paper was really to get kind of technical, actually. It wasn't meant to explain what these crisis services are in detail or provide all the evidence for it. It was a summary of, like, if you want to broaden your reimbursement for beyond either Medicaid or Medicaid waivers or grant funds, this is one of the ways to do it. So, as I said earlier, it recommends some existing codes, and the goal here is to get adequate reimbursement, which, as many of you know, has been a challenge with more, standard, even regular psychotherapy or psychiatric medication management, et cetera. A lot of those services are still not adequately reimbursed by insurers of all types. So the goal here is by using standardized codes and asking for the full cost of the coverage for this, that we can now move to a multi-insurer billing mechanism. So we go to the next slide. So one of the things to recognize, though, these are recommended codes because they exist. Many of those have tried to go through creating a new code, whether it was through CMS or through the AMA CPT code. Those are the two ways you establish or use billing codes. But getting a new code can often take a long time, and sometimes 1, 2, or 3 years. So the advice we got from Brenda Jackson and others, and based on what are some of the current billing mechanisms already in place in different states, we identified existing codes that would match at least 3 levels of crisis services care. But the goal here is to have, crisis mental health and substance use services that mirror what's available on the healthcare side, right? You need to be able to call somebody if you're in a crisis, whether it's for suicide, and you need to then get some guidance about where to go. You also you need some level of mobility and somebody who can outreach to you. And that means a mobile team, which we have that on the healthcare side. We just don't have it consistently on the mental health and substance abuse side. And finally, you need to go somewhere to get these services. And so let's go on to the next slide. So these are the levels of service and the recommended codes to use. So actually, I was sort of surprised, and maybe Paul or David knew this, but I didn't know there was a code for a call center for a crisis line, but apparently there is. When I know I'd say a moderate amount about billing codes, but I'm not an expert. And when you talk to an expert like Brenda or some of the other people, you learn a lot. And so it obviously on the crisis side, you're not going to know ahead of time who's got insurance or who's not. But so some of the people will be billed using this existing code. But the 2 most expensive things here is having a mobile crisis team and a crisis stabilization place. And they're described here with the specific codes that could be used. I do want to point out, this is sort of the start point for a provider, is to use these codes to bill for what they're already billing Medicare, Medicaid, and or a grant program for. And it may be that the commercial insurer or Medicaid fee-for-service or Medicaid MCO that's not currently paying for these crisis services, they may respond and say, well, I have a better way to do this, or I want to use a unique coding, or I want to give you a case rate. That's fine. This allows you to start the conversation of giving them a specific service type and also to give a proposed code. And that's I think the first step in this process of establishing the whole billing situation. You want to go on to the next? So, my background, I spent 10 years in the public mental health system in Maryland, and 3 of those years as director of the state mental health system. That's when I met Brian Hepburn, and I was one of the people that recruited Brian into the public mental health system back in the 80s. I think he was still in high school then, but he came straight right into working with us. But it's interesting to me, having been in the private and the public mental health systems for most of my career, one or the other, is that the public mental health systems have developed some key essential services, but they are not fully reimbursed throughout all insurance entities. So, and I include crisis for that, first episode psychosis or coordinated specialty care, and ACT teams are three of these things that have been proven, validated, reimbursed in, I would call, I guess to put it nicely, fragmented funding, meaning sometimes it's a Medicaid waiver, it's sometimes a mix of some Medicaid funding and grant funding. And if we are to get mental health and substance use services, particularly those essential levels that have been piloted and developed within the public mental health system, like everything else in healthcare, we need standardized coding and we need all insurers to pay. So that's the goal here. I don't for 1 minute think it's going to be easy. Like as I mentioned, and those of you who saw the Department of Labor report in January on their increased activity on auditing self-insured employers and health insurance issuers and carriers, that there were a lot of problems with parity compliance. It really helps them to be able to coordinate their care much better. Can you hear me okay? I don't think that's my background anyway. So I think one of the questions would be, and we could have some discussion on this, is what are the steps? What do we need to do to move forward on this? And I think one of the things we've learned we did a similar paper like this a couple of years ago that Meadows and others helped with this, the Bowman Family Foundation, to create standardized codes for first episode or coordinated specialty care, is we really need some either state or national level coordination support for this. I don't think we need a huge team, maybe one or two people, to help providers get this going. And the help I think that's needed is, first of all, if a crisis provider is already in network with a commercial payer or Medicaid, then you're already in the network. So then it's a matter of getting established for this service type. So some providers, a community behavioral program or others may already be in network, but only for maybe professional services or inpatient or other things. So if you're not in network, I think the first step will be joining a network of the local insurers, whether they're national or state level insurers. And the first step there, whether you're in or out of network, is preparing what I would say is a well-developed ask. These codes are one thing, and given that many insurers, particularly outside of Medicaid, may not be aware of what crisis services are, their definition, what I would recommend for providers, and if we get the resources to provide some coordinated help on this, would develop kind of a model ask that would reference the Samsa paper, would reference this billing paper. So an insurer who may not know what these services are, okay, or that they exist now as a specialty mental health and substance abuse service, would have some background, would know the evidence, and then they would have a billing code with a request for payment. So that's the first step. What I imagine is going to happen a lot is, because insurance and many insurers are not used to paying for this, and that probably includes Medicare and Medicaid fee-for-service or Medicaid MCOs that haven't been paying for these, or certainly commercial carriers. They may either ignore this or not reimburse it. And the next step, I think, would help to have model letters. What you do next is you basically ask for reconsideration by the insurance company, and then you ask for disclosure of why and for what reason did they not pay. And this is where the parity law comes into play. Any beneficiary or provider acting on behalf of beneficiary, if you have requested payment and it's refused and you feel it's a parity violation, you can ask, and the insurer is required to give you all of the reasons why they wouldn't pay for this, and why and what rationale. What might they say? It's experimental, or we don't recognize it, we just exclude this. or we don't want to pay it. We don't think it's necessary. So all of those become part of the parity appeal process. And I think part of the work here would be to help establish kind of a standard letter that explains what this is, and then also what are the rationales and what are the analyses that an insurance company has used. Because what they have to do is show that, well, if you block this, but you pay for the full range of healthcare service, emergency services and crisis services, urgent care services, then they are going to have a hard time saying that they cannot pay for this for mental health and substance abuse. So, so I think that to really go this route, because this will be a challenge, and many, public sector providers, they're used to billing grants, they're used to billing some Medicaid in their states. It's a pain in the neck. I mean, let's be honest, to bill all these different insurers, and the more help that we could provide nationally or at a state level that make this easier for them and help them work through the sometimes Byzantine processes that insurers do, I think that would make this more real. And I think the goal is, as a first step, would be to get interested providers in multiple states to start the process with multiple insurers, and then provide some help on getting this established. Once a state or a federal regulator calls an insurer on this by not being consistent with the parity law, it's going to set the stage for everybody else. So let me stop there. And I know, Paul, you're going to make some comments. Is that right? And maybe we can even have a little discussion about how do we make this happen and make this real? And Brian also.
Yes, thank you so much, Dr. Harbin. Paul and Brian, I'll go ahead and turn it over to you.
Thanks, Aisha. So Henry, I think great job. You talked about next steps for us. And I will say that one of the things that it's about as simple as it can be when you think of the table around coding. It's the same table we have in the national guidelines for behavioral health crisis care published by Samsa. It's there's one call center code, there's one mobile response code, there's really one facility-based code, and hourly and a per diem option. And I think that sort of clean approach works really well. And I'll tell you, as a crisis provider that's contracted in 10 states, our challenge is states are really trying to bring this to life. But if you want the commercial payers and Medicare to do their part, having the same code state by state really gets you a lot further than, hey, we do something unique and different here, we want to get you to pay it. And so I think, Henry, you really leaned into that well. It's about consistent coding that Medicare is also going to recognize in these commercial payers.
Right, Paul, that's very accurate. This is, the goal would be to have this more standardized. And again, if some insurers say, well, I've got a different code, I want to, as long as they're going to pay the full amount and they're going to do it rapidly, that's fine. Even though I think over time you'd want it standardized because it puts less of a burden on the providers. And eventually the insurers less. Brian?
Yeah, Henry, so thank you very much. It's great to see you again. And Paul, thank you for your comments. Yeah, Henry, I thought it was a good overview. And I know there are people, many of us, the last thing we want to talk about is funding, right? And there are many people on the call, they'll be thinking, oh my God, we have to talk about funding. But when we look at the success of 988 and crisis services, it's only going to be achieved through sustainability. And I think what you're putting forward, Henry, with the billing codes, but also with the parity, is a way of us moving forward and achieving sustainability. So would you mind saying a few words about how in the short term, because there's so much federal money out there right now, it may not be needed, but in terms of our long-term financial funding sustainability for crisis services, how important this is?
Well, it is, Brian. I know there's been a lot of money over the last couple of years for this, but I can't imagine that every person who's got commercial insurance or Medicare or standard Medicaid, not every Medicaid agency pays for this, right? So I think it would be something you'd want to do right away, Brian, because one of the things about some of these very essential public mental health system services, and Brian, you know this from, having played the same roles I have in the past. When you're not used to billing for these services to everybody, you sort of leave a lot of people on the sidelines, right? They're the ones, they may never show up at the crisis service. They go to the ER, right? Or they end up in jail, or they end up somewhere else. So I think it's important to move on this immediately and recognizing that it is a challenge. That's why I think having some national coordination help on this would help, get the providers used to this. And so, I think it's important for the community providers, because this is the same just true for the coordinated specialty care, right? Is getting used to being in network for commercial, being in network for Medicaid, whether they have a waiver or whether they have specialized funding. One of the things that's always struck me, and this is particularly true of the public mental health system, but it's true for the private mental health system as well, is we as a sub-segment of healthcare do not utilize the general healthcare system as well as all of these people with physical medical problems, right? And their providers. When I talk to specialty providers in other areas, they spend tremendous amount of time on refining and getting billing codes that match what they do. So, and I don't see enough of that in the public mental health system or the mental health system in general, Brian. It's like, we should be paying attention so we get the full support from the general healthcare system that we need and deserve, right? And so, mental health is, 3 to 5% of total spending in the commercial world, higher than that in Medicaid, somewhere in between on Medicare. But if we met the need, it's going to be a lot higher. So I think that's the reason for this. And I think it would be really important as a way to mainstream all the current specialty providers, particularly those in the public mental health system that deliver these types of essential services, to join in and become part of the whole healthcare system.
So just one quick question, Henry. You're somebody that's been championing parity in behavioral health for quite a while. When we look at the success in achieving parity, it's not very impressive over the last few years.
Right.
What's the window of opportunity here, and what is it that needs to be done to shift away from being unsuccessful with parity to being successful in achieving parity?
Good question, Brian. Yeah, the parity regulations since 2008, I think have been pretty good. Every couple of years, the Department of Labor, both under Obama and under Trump and now under Biden, have issued greater and greater specificity. But the enforcement side has been lagging, Brian. And this really is what the enforcement here is that's been lagging is on what's called the non-quantifiable treatment limitation. So actually, when you look at success on parity on the financial, there are three things that are regulated by parity. The financial requirements have to be comparable, like co-pays and dollar limits, and treatment and quantitative treatment limits, like 30 days limit on mental health, but unlimited, inpatient days on medical. There's been pretty good compliance in those areas. Most of the insurers have removed the financial differences on co-pays, deductibles. They have removed the quantitative. It's all the battles, the lawsuits, the enforcement is all around the non-quantifiable treatment limitations. And part of that is the lack of transparency and enforcement. So, I think when you look at it, Brian, when you work for a big organization that has a compliance department, if the rules are clear, they're going to enforce it, right? When the rules aren't as clear on what's required, what's not required, you see this inconsistency in enforcement. So the issue of whether you exclude, say, coverage altogether for crisis. So you apply for this and say, we don't recognize that service. That is a NQTL or a non-quantifiable treatment limitation, right? Or if you don't reimburse adequately, or if you don't have enough providers and bring them in the network, all of those are examples of non-quantifiable treatment limitations. The CAA that passed at the end of 2020 added some additional requirements and authority for the Department of Labor on doing these audits and some additional statutory language. And the DOL report that came out in January showed how much more proactive the Department of Labor is being and many state regulators on this issue. So I expect we're going to get a lot more support from state and federal parity regulators on crisis and any other areas that are being underpaid or neglected or not being. And so the interesting thing here, these services are likely going to be compared to the emergency services benefit. The parity law lays out, Brian, several levels of types of benefits: inpatient, outpatient, emergency services, and pharmacy. And so these non-quantifiable treatment limits are applied within that class. So this type of service could fit the emergency class or the outpatient other or outpatient facility class. I think they fit both. If it's in the emergency services, no pre-auth is going to be required because there's no pre-authorization required for emergency medical services. So that's going to be a little bit of the work I think we could do to try to help, position these requests. And if they are, not responded to, Brian, that we could help try to refine and make that smoother for the enforcement of these services when they're requested. So.
Well, thank you, Henry. Good discussion, and we look forward to working with you further in the future. Thank you.
Okay, thanks for inviting me. It's really important work that you all have done with this. So I'll try to be helpful with as we go to the next stage.
Thank you.
Henry.
Thank you so much, Dr. Harbin, and thank you, Dr. Hepburn and Paul, for your comments. I see that there's a really robust conversation happening in the chat, so definitely please continue that as we go. I love to see folks learning from one another during these meetings. Can I get the next slide? And I'm going to call up Sarah Corcoran. Sarah, I know you got a little bit of a reprieve when I tried to call you early, when I was going to call you early, but you're now up for the trivia hot seat. So Sarah is the Vice President of Government Relations with Guide Consulting Services. And Sarah, you have the, I think, exciting opportunity to do a new kind of trivia hot seat. So you're going to get 4 questions. All 4 questions have the same 4 options for answers, but you do have to answer all of them. And you won't, because of that, get a chance to phone a friend, but you are going to still get the audience feedback. So you can learn from the wisdom of the crowd or go with the wisdom of the crowd. So the first question: in 2010, Georgia expanded crisis stabilization programs, developed statewide community mobile crisis teams, added crisis apartments, and expanded the statewide crisis line. What was the primary driver for the state's substantial investment in the crisis continuum?
Okay, well, this is tough.
Yeah, and you can let the crowd answer. They'll go ahead and, everyone on the phone can select your choice. And in a couple seconds, we'll have a little bit of sense there. So.
I know we have a lot of Georgia people on the line, so I really hope the numbers have shown up today to help with this question.
All right, Sarah.
That was going to be my guess, but I was not sure because I am definitely not from the state of Georgia, so I am not aware of what has happened at least up until now. I know the great work that they do, so I was going to go with C on this question.
Great. Next question. You're correct. C. While many states were forced to reduce behavioral health care funding due to the Great Recession, Georgia's DOJ settlement agreement led to significantly expanded crisis services. So you and the crowd are correct.
Thank you, crowd.
Next question. In 2013, Colorado crafted RFPs for a comprehensive statewide crisis system, including crisis line, stabilization facilities, community mobile teams, respite and residential, and marketing. So beyond improving population health outcomes, what was the primary driver for the state? And as the crowd answers, you can give us your answer, or you can wait to see what the wisdom of the crowd says.
Okay, well, I'm gonna wait for the crowd, but just kind of thinking through, I've heard about how Colorado was one of the early states in this kind of more transformative view of crisis. So I'm leaning towards public safety, but it could be cost effectiveness. I'm not sure. So I'm definitely looking towards, oh, okay. Well, I'm very close here. Slight edge to public safety. So I will go with B on that, but I am pretty split between A and B.
For you. And the
Okay.
gap by a nose is correct. So in response to the 2012 Aurora Theater shooting, Governor Hickenlooper initiated Strengthening Colorado's Mental Health Plan, a plan to safeguard all Coloradans. And I do just want to say, I know many of the folks on the call today are really aware of the kind of complex and complicated relationship between mental health and crisis and violence. And we all know that people with mental health needs and people in crisis are more likely to be subject to violence than be perpetrators. However, we do know that in this case, just before the shooting, the shooter called a crisis line and did not have his call answered. And so, that also drove some thinking in Colorado's their mental health system plan. So good work, Sarah. Good work, crowd. Next slide. So in 2005, Arizona began to dramatically increase its core crisis capacity and innovated with regional crisis lines, no wrong door crisis receiving facilities, and community mobile teams. Beyond improving population health outcomes, what was the primary driver for the state?
Well, I know I've got two left here, so I'm gonna guess that it's cost effectiveness because I know Arizona has really invested in really creating a comprehensive system and has seen a lot of dividends for that that investment. Of course, besides the outcomes for individuals that have been improved. But I would like to also see what the crowd answer is before I. Okay, well, that's the one I'm going to go with then.
All right, cost effectiveness it is. So definitely there were multiple drivers for Arizona's leveraging of federal Medicaid and competitive health plan management. Envision a 2-to-1 return, envision a 2-to-1 investment, return on investment dollars. So certainly lots of reasons, but cost savings and cost effectiveness was a key driver. Last one, and so you're on the home stretch with this one, but in fall of 2014, Washington State sprinted to invest in additional evaluation and treatment bed capacity for those who required involuntary care in a mental health crisis. So what was the primary driver for the state in this case?
Well, unless you guys are trying to throw me a curveball here, I'm gonna take a wild guess that it is option D, but I would, of course, welcome audience input because I also know Washington State is another one that has pretty strong numbers every week on this call. Okay, well then, yes, I'm hoping that there's no weird curveball where it's a double answer, but I will go with D again.
It's enough to make you do a totally different type of trivia hot seat without sending you for a curveball. So you're correct, hospital boarding, as well as folks on the phone. Congratulations on your 4 for 4. You hit it out of the park. So in 2014, Washington Supreme Court ruling banned psychiatric boarding in the hospital EDs. However, the investment that follows were primarily in acute care, not the crisis continuum, but you are correct that the driver was around hospital boarding. Great job. Thank you so much, and great job to the audience. You all, I think, also got a 4 for 4, if I'm remembering correctly. So
yes, thank you to the audience again. Sorry to interrupt, but thank you again for the audience help here. I would not have been able to do 4 for 4 without it. So thank you.
I appreciate it, Sarah. All right, now really excited to bring up Stephanie Hepburn and Captain John Gannon to talk about the conversation that they had around how 911 is triaging calls, particularly behavioral health crisis calls. So Stephanie, can I turn it to you?
Yeah, thank you, Aisha. So Captain John Gannon, he's from the LA, sorry, I live in Louisiana, in the LA County Sheriff's Department, and we chatted about LA County's 911 assessment matrix for their calls and their amended call procedures. Captain Gannon, are you on the call?
I am. Hi, everybody.
So calls that come into LA County's 911 call center are by default considered higher risk. And with the new call assessment matrix and the amended call procedures, how does that ensure that most behavioral health calls will divert to D.D. Hirsch mental health services?
Well, thank you for the question. So in theory, all calls are considered immediate threat to public safety or some crime has been committed or people wouldn't be calling 911. But in actual practice, we know that's definitely not the case. Just something to consider. We are the branch of government that's open 24 hours a day. People know that number and they are not afraid to use it. So our hope is that with 988 going live, we will be able to divert all calls to the 988 system that do not involve a threat to immediate public safety and or a crime that requires or mandates that we conduct an investigation in the field. So currently, when a call comes into 911 and we screen the call, we attempt to transfer calls that are non-law enforcement related directly over to our Department of Mental Health in LA County. That would be in the matrix, that'll be in the article, that would be what we consider moderate risk.
Yeah,
call.
and I tried to add the photo. I don't know if you can see it. I tried to actually add the photo in the chat.
Oh, okay, good. Yeah, so we have a 4-level matrix that we adopted in LA County last year that we are training all of our 911 dispatchers now on how to call screen and the proper questions to ask and whatnot to more quickly identify which calls law enforcement actually needs to respond to, and which calls we can divert to a better authority. So say in the future, 988 or D.D. Hirsch, which is currently doing a pilot in the city of Los Angeles, is accepting what will be our 988 system calls of the future. But otherwise, the Department of Mental Health also receives calls directly. So it's a little complicated right now in LA County. 988 will simplify that, where we will simply do a screening. And if it doesn't meet one of our initial 3 criteria, then the 911 operator is trained to transfer the call live, have the 988 system operator come up on the line with us. We'll screen the call together. And then when it's accepted that it actually meets the criteria for a 988 call, then we will drop off the line at that time. So we'll probably have about a minute of overlap on those calls as our goal. And then that will be dispatched through the 988 system. So in our matrix, we will consider all 988 calls automatically a level 2. Until proven otherwise, they will try to handle that call on the call itself, through the crisis hotline, as opposed to sending a field response team by default, which sometimes is the case in law enforcement. When you have nothing else to offer, we tend to send a patrol officer. That's often not the best remedy, as you know.
And you mentioned too that a level 4, which is the higher or highest risk call, that would result in a co-dispatch, I believe. So
Yes,
mobile crisis would also be dispatched.
That's right. So if patrol is responding, our goal in LA County and what we're working toward is to eventually have a co-response team responding to those calls in real time, dispatch them in real time with patrol, so that you don't just send a law enforcement officer to these calls. We'll have a mental health clinician and in some cases like a peer responder as well with us as part of those co-response teams.
And something I thought was really interesting was in the calls, some of the questions, there's a distinction between what's considered an emergency versus a crisis. And you don't have to go too much into it, but I wanted to let readers know that you do draw that distinction.
Yeah, I mean, medical aid doesn't automatically require a law enforcement response, for example. It's possible to send a co-response team without patrol, black and white and uniformed officers. And another call that we are looking at very carefully is we may send only a corresponder, or preferentially we would handle it as a level 2 using a crisis hotline like our D.D. Hirsch program for people who pose a threat only to themselves, may have a weapon, but let's say they're in their house and they're not outside creating a threat to the public or immediate danger. Why send a law enforcement officer to a person threatening suicide when we're delivering the weapon they may seek? So we are rethinking those, what used to be considered emergencies, and may actually omit law enforcement from those calls in the future.
Thank you so much, Captain Gannon. Back to you, Aisha.
Thank you so much, Stephanie and Captain Gannon. It's really exciting to hear about how you're thinking about making sure that the right kind of response gets to people in that moment, and how you're also triaging really important and precious public safety resources. So making sure that when a co-response team is needed or when law enforcement is or is not needed, that's being taken care of at the point of the call. And I also see tons of conversation in the chat. So Captain Gannon, I'm seeing some shout outs about the work that you're doing. I just want to draw your attention to that. Next up, I think we have our Samsa update. So Dr. Palmieri, John, are you in the room? I can call up for you.
Yeah, hi, thank you. And thank you all for engagement, ongoing work, partnership. Thanks to Brian and David also for making this such a robust environment for learning. So just quickly, the date has been finalized for the second part of our national convening, focused on 988 readiness and implementation. That will be a continuation of a convening that happened in early February. This one driving forward with some specific operational tools and supports to advance readiness, to provide some increased alignment on an overall roadmap, and also to settle in on some next phases of activity with respect to ongoing learning. That will be March 24th. 1 o'clock Eastern time, and I will throw a registration link in the chat so people have an opportunity to sign up for that. And then also just wanted, I think there'll be a coverage of this in a few moments in this meeting, but we are also tracking the FY22 omnibus appropriations language, which just came out overnight. And also, of course, tracking the president's proposed budget, which for 23, which should be coming out later this month. And then I'll just pass it off to Richard to see if there are any other Samsa updates.
Thanks, John. So I would just mention, and it was great to hear the report out from Los Angeles on the work that they're doing there, including the 911 to 988 diversion work. So we have a number of lines of efforts. One piece of that will be in the convening that John just mentioned. We are also working on a policy academy on 988, 911 coordination. There was a requirement in the state, the funding, $105 million that went to states to fund local crisis centers, asking for a plan on 988, 911 coordination. But I also wanted to amplify a quote that Sandri Kramer made in the chat. And I was privileged to go and see the system that they have in Los Angeles, and which I think is a great program, that is diverting from 911 and diverting from police needing to be sent, right now. But Sandri's, chat highlighted a major gap, which is a funding source for these kinds of diversion programs. I'm trying to, understand better who's using funding how. It's, for these kinds of efforts. Washington, D.C. has a program that they're using American Rescue Plan funds for, which is great, but it's not a long-term solution. Not sure about how they're funding it through Harris County and elsewhere. But I think this is a really important part of 988 implementation. And so those will be issues that will be important to get further analysis moving forward if, the great programs that are going on in Harris County and Los Angeles and St. Louis are going to be able to be sustained over time and achieve kind of that full vision for 988 implementation. That's an area that will need continuing work.
Here, Dr. Palmieri and Dr. McKeon for those updates. I think then we're going to go ahead and move on to the national updates. Dr. Brian Hepburn, can I call you back up?
Thank you, Aisha, and thank you for your good work. Also, thank you to John and Richard and Samsa team It's pretty impressive, the work that's being done with 988 preparedness. And we in the States, we look forward to the convening on March 24th. So thank you for that. Next slide, please. So I wanted to bring in Aaron Walker. Aaron, do you want to say a few words about this slide?
Sure. Good day, everybody. We just wanted to reshare the links to the paper, the state's experiences in legislating 988 and crisis service systems, as well as the 988 state model legislation for behavioral health crisis service systems. And also in the chat, I am also sharing a link to a slide presentation that actually explains the state model legislation section by section, which is also very helpful. So definitely please continue to share this far and wide. And thank you all for your partnership. And I'll turn it back to you, Brian.
Thanks, Aaron. And Aaron, will you put the links in the chat so people will have it?
Will do.
Thank you. Next slide, please. So I just wanted to say real quickly, two of the papers that we have were done by Sharon Hoover and Jeff Bostic. And one of the papers is on school mental health, and the second is moving the KID system to 988. I think this is very timely to review because of the fact that so many kids now are going back to school. Hopefully we're in a post or close to post-COVID time period, but it does bring up a lot of the attention that's needed in school mental health and in kids crisis services. So we'll put, I've asked Megan to put those links in the chat as well. So back to you, Aisha. Thank you.
Thank you so much, Brian. And as always, you all are putting out really useful resources. So thank you for sharing that with us. Next, I'd like to call up Sarah and as well as Joanna to give us a lay of the land on some of the federal, what's going on at the federal level.
Thank you, Aisha. As John Palmieri mentioned earlier, last night at 1:30 in the morning, they released the text for the FY22 omnibus. There's also going to be a vote for a 4-day continuing resolution alongside of that, so that there is enough time procedurally to still to kind of go through the process to get the FY22 bill passed, especially in the Senate, without having to deal with a potential shutdown at midnight Friday into Saturday as it currently stands. So those numbers, as we expected, are very strong. There is a $100 million increase for the mental health block grant. That includes the continuation of that 5% crisis care set aside, as well as the creation of a new 10% set aside on early prevention and intervention. There is $10 million for a new mobile crisis pilot. As you'll recall, that was funded at $100 million in the House version of the FY22 appropriations bill last year, and it was not included in the Senate bill. So at this point, they are creating the program, but funding it at a lower level of $10 million. They also have $101.6 million for the Lifeline, as well as $315 million for the Certified Community Behavioral Health Clinic Samsa grant line item, as well as $5 million for that 988 coordinating office within Samsa. Just an overall really strong bill. And I'll also mention that there is an extension of that telehealth in-person requirement for mental health services only past the end of the public health emergency for 151 extra days. That will not go into effect, and that is something that has not yet gone into effect, but would theoretically otherwise go into effect at the end of the public health emergency. So I will include a few links to some of the summary documents, as well as the committee report language text, expecting to see this potentially passed by Monday or Tuesday, but it's a great day for mental health funding for the rest of FY22, and will officially kick off the FY23 process in the House and Senate pretty soon. Thank you.
Thank you so much, Sarah. Appreciate the update and hearing some of that good news there. So then I think what I can do is go to the next slide now.
I'm just going
Oh,
to,
sorry, Joanna.
sorry,
Apologies.
so sorry, I'm
Apologies,
just gonna
no.
step in.
Please,
And
please.
just quickly note, we've been waiting for the 988 Implementation Act to be introduced. It was supposed to be introduced yesterday, but due to some scheduling conflicts among the co-sponsors, they are coordinating a new introduction date as well as a virtual press release statement. So we're waiting for that. Hopefully in the next week or so, we'll receive that and we'll be sure to share with everyone. Thank you. Sorry about that, Aisha.
Oh, no, sorry. I totally called you up and then tried to skip you. So my apologies. Next slide. I think we're going to go ahead and just turn to the NAMI team to give us a little bit of an update on their map of the 988 legislation too. So do I have Laura or Steph on the phone?
Yeah, this is Steph Pasternak from NAMI. I'll just be very brief. A couple pieces of legislation that have passed their legislatures that I want to highlight quickly. In Washington State, House Bill 1688, I think it was mentioned earlier in the chat actually by Paul. So this is exciting because this is all about insurance coverage for behavioral health crisis services. And this, as of Monday, has passed both chambers, and it strengthens commercial insurance coverage of behavioral health crisis care by expanding the definition of emergency services to include post-stabilization services and emergency services provided by behavioral health emergency services providers, and also protects consumers from out-of-network healthcare costs. Also, just quickly, West Virginia's 988 implementation legislation, which is essentially very much based on the NASBID model bill, except for that model, that fee provision is not in there, has also cleared both chambers and it's on its way to the governor. That's Senate Bill 181. So more good news there. There's also been many 988 bill hearings this week. I don't know if Laura or Jordan from Vibrant want to jump in and cover those. I'm also happy to cover them though.
Thanks, Steph. Happy to jump in for New Jersey. We are hearing that unfortunately it does not look like the bill there will be moving forward, at least with a fee. But we are hearing that there will be money allocated in the budget for New Jersey. So I think that's the latest update. They were just heard yesterday or Monday, I believe, in committee. And then also hearing Kentucky has budget money for 988 implementation, and that's a must-pass bill. So we are seeing that the must-pass bills are including some provisions or funding, at least for 988 implementation, where the standalone bills that contain a fee are facing a little bit of a higher challenge this year, particularly it being an election year for many states.
Thank you so much. And as we click through the next slides, you'll see that there's some information. These cards for states that have passed significant legislation are on the Crisis Talk Now website. And so you can find these and learn a little bit more about what's going on in the states. And then the last 2 minutes, what I'd like to do is call up Amy Burns just to give us a little bit on the data corner, and then I'll send you all home.
Sure thing. Thank you. And I want to specifically thank Dr. Goldman for the invitation. So I'm just here very quickly to make you aware that Samsa is working on a federal data and evaluation plan for 988. And to do this, we're working with our data and evaluation partners across the Department of Health and Human Services and other related federal programs. The primary focus of our 988 efforts, we're primarily focused on 988 efforts, but also looking at some of the longer term measures of the crisis continuum. And these efforts will really dovetail with the suicide related goals in Healthy People 2030, which are the metrics that ground all federal efforts around major public health issues. For this evaluation plan, our impact statement is to create a holistic crisis continuum throughout the US and its territories, and in collaboration with tribal nations and citizens that is centered around local response. And so to do this, HHS is focusing on measuring 4 key efforts within this. The first is to strengthen, expand, and maintain the 988 network and deliver a seamless, high-quality experience for call, chat, and text users. The second is to have one federal body responsible for overseeing 988 and crisis coordination efforts. The third effort is to commit to continuous improvement driven by evidence, innovation, and measurement-based care. And finally, the fourth is to integrate behavioral health services into one transformed behavioral health crisis care system. So we've been working and identified potential measures for each of these efforts, and we're working with the HHS Behavioral Health Coordination Council, or the BHCC, to map out these measures to existing data sources. We are also identifying opportunities to potentially add new measures to existing systems across HHS. And then once that exercise is completed, we'll move on to benchmarking and goal setting for our near-term and midterm outcomes. And then, really the purpose of this document is to just serve as a vision for HHS moving forward. And we will be sharing it once it's completed. And that's my really fast overview for you.
Thank you so much, Amy. Can I get the final slide? There's a few things we didn't get to. You can keep going towards the end. I know we're at time. And so please join us next time for a conversation with Samsa. For the main presentation will be at Samsa's 988 Communication and Partner Toolkit. And I just want to thank everyone for joining us. The work that you all are doing to improve crisis systems and improve healthcare is critical now, as it always has been. And I'm just deeply impressed by the thoughtfulness of everyone in this room and the work that you are doing and the way in which you engage with the material during this call. So thank you all so much, and thank you for having me. Have a good rest of your Wednesday.